healthcare is still
okay, sorry about that. Let me go back again. Let me stop share and okay. So like I said, in Alma Ata in 1978, the then USSR, now Russia, the way to achieve health for all was through primary health care in the year 2000. So that's when the concept of primary health care. So it was a conference of health ministers, health organizations about the health status of the whole world. So what actually brought about this was the gap that was seen. There seemed to be a great gap between, there was the basic thing that brought out the concept of primary healthcare is to healthcare. There was this gap between the haves and the have-nots, between the developing and the developed country, and the rest of them. Some group of people, both in terms of quality and quantity, compared to other group of people. So this was actually what led to the concept of primary health care. So there was a representative of 134 countries, including Nigeria. So like I said, it was the inequity and injustice that prompted this concept to come up. So, and we should remember that the report of this conference is what is popularly referred to as the Declaration of the Alma Ata, or Alma Ata Declaration. So what was this declaration? It expressed the need for urgent action by all governments, all health and development workers, and the world community to protect and promote the health of all people of the world. It was the first international declaration underlining the importance of primary health care. Basically explained the need for primary health care and what it entails. So it proposed that primary health care was the basic strategy for achieving health for all. Health for all, that is a level of healthcare that will enable the people to live socially and economically productive life. So this particular concept gained 1981. This was a departure from previous ideas and concepts of healthcare. So primary healthcare is very, very unique in its approach, to achieving health for all. It's worthy of note as we go on is the fact that on it's the success of the primary health care program. Okay, can you hear me now? Okay, I say primary health care was actually very unique compared to previous concepts. It's defined, it's a very long definition, but then we are actually expected to know it, and most times it's expected that you know it, but then what to know is to know there are basic things that if you remember it will help you to be able to, if not verbatim, in red. So primary health care is essential health care that is based on practical, scientifically sound, and socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community maintain at every stage of their development in the spirit of self-reliance and self-determination. So it's sound, and it must be socially acceptable to the people you are providing it for. accessible to all, and it has to be with their full participation, and they must have to sustain. If you have provided it, to be at such a level where they can continue even when you are gone. So self-reliance and self-importance. So that is just about it. We should just remember those key terms. So it actually forms an intelligent, and it is the first level of contact. We know that we kind of have a reversal of things around here, but normally primary healthcare is not or for the people who cannot afford quality health. It's not quality of health. It actually should be the first contact of every individual. If all things being equal, there's the ladder that should be followed, from the primary, then based on what it is can be referred to the secondary, then the tertiary. So our tertiary institutions are actually not meant to be the first point of call. They're meant for research and training, cases and all that. So it's very integral for any country's health. In Nigeria, it's popularly said that the father of PHC is Professor Olukoyo Ramson Kuti. And so the history of evolution of Nigerian health system, primary health care. As a country, we've made several attempts, as we would see, before the adoption of primary health care as a means of achieving health for all. So intended to deliver health services, training, research, financing, etc. It is described as all of the organizations, institutions, resources, and the people whose primary purpose is to improve. This might not be so important to us, but I'll just say that these are the components of the health system. There are concepts such as health as is a concept. Then there are ideas such as equity, coverage, effectiveness, efficiency, impact. Then the objects, then the persons or the human resource for health, that is HRH, which is providers and as well as the consumers who are also involved, who consume the health services provided. So together, so the healthcare services in Nigeria have been characterized with by short-term planning, as it is the case with planning of most aspects of Nigerian life, permit me to say. So I'll just pinpoint the major development plans that we've had so far. Although even though this is more like the ones that are nationwide health services provision, but even before that, there were small structures in place, but maybe not necessarily nationwide. We've had like the colonial masters providing health for themselves, maybe at the mines or places where they come, basically for themselves. Or we had the ones like the railway and all that, which were in place. We've had some hospitals being set up and all that before this general health service for the whole nation. So for the one involving the whole nation, the first is the first colonial development plan, 1945 to 1955. So it was actually a decade of development. Then the second colonial development plan, which was from 1956 to 62. Then after this, then we now had the first national development plan from 62 to 68. There were like 5-yearly plan like that. So the second was the national development plan of 1970 to 1975. Then the third was the National Development Plan from 1975 to 1988. Worthy of note is this third plan. So said to be like the most successful amongst the rest, though it had its own shortcomings, but it had a concept that was similar to primary health care. And this was even before the world started talking about primary health care. People started incorporating primary health care. So in a way, we're said to be ahead of others, and we had what was similar to primary health care. Then the fourth National Development Plan of 1981 to 1985. Some will tell you that there was a fifth National Development Plan, but this was actually discarded as there was a lot of let's say lack of political will, instability. There's this 5-year plan, a government starts it, once the government leaves office, it is discarded. So a lot of effort were kind of disjointed. There was lack of continuity and all the rest of them. So instead, they now started doing what was more like the rolling plan, as from this point. And there are three ways you could plan. You could have a flexible plan, a rolling plan, and no, a plan could either be fixed or rolling. So for the rolling is more flexible. For the rolling plan, things change. Where we were in the year 2000 is not where we are today. A lot has changed in the world. We have occurrences of epidemics, and the rest of them, emerging and re-emerging of diseases and all sorts. So because of that, they needed to have a game plan that was different from what they were doing before. So that is where the rolling plans came into being, such that yearly there's a kind of re-evaluation, and then a feedback is done into the system to change certain things based on what is on ground. So that was what the rolling plans were more like. So so just to continue from that, then worthy of note is the fact that we had the national health policy for the first time, which was in 1988, then revised in the year 2004, which is that of 2016. And this was necessary because the times have changed and what was obtainable now, and there needed to be a lot of change. So we now have a new health policy. National Development Plan of the fourth one, we now had Nigerian, and after the rolling plans and all that, we now had Nigeria plan 2004 to 2008. Then the National Strategic Health Development Plan, this was the first one, and that was from I know it's a lot of history, and I hope it's not boring. So because we have a discipline too in public health that has to do with history. So I just hope we're able to pick one or two things. Then the 2014, also which is the second of its kind, National Strategic Health from 2018 to 2022. And what I want us to take note of is that it has 5 strategic pillars, 15 priorities, and 48 strategic objectives. So note of that. And part of the reason, before I forget, why the national of 2016 was also necessary. Before we're running on the MDGs, now we're talking on in that same light too, things had changed, and so we needed to incorporate that, and come up. So let's just
excuse me, please. Your voice is breaking.
Oh, I'm so sorry. Me? But can you hear me clearly now?
We can hear you clearly, but then it goes off after a while and then comes back.
Oh, so sorry.
Yeah.
Okay. Okay. Maybe I could repeat it. Health policy of 2016. Hello.
Yes, doctor, we can hear you. Yes, health policy of 2016. You were explaining why it was necessary.
Okay. Have changed. What was obtainable then is no longer what is now. So we have a lot of emerging and re-emerging of diseases. We talk of some kind of what we call epidemiological transition. Formerly, as developing countries, we're dealing with infectious diseases, like we discussed when we're communicable disease epidemiology. So we're dealing with that, but as it is now, we are having a double barrel of, communicable, and we have the non-communicable. So a lot these changes is what necessitated a new talking about the MDGs now having the SDGs and the rest of them. So for what strategic health development plan, and I said we should take note of the fact that it has 5 strategic pillars, 15 goals, and 48 objectives. So we should take note of that. Okay. The public health services from the British Army Medical Services. So if going further is planned, but I don't want to bore us with that. I'll give it to us later. But then for the one I would like to stay on a bit, which I said was most important of our plans, most successful of our health planning in Nigeria was the 1975 to 1980. This was what was called the Basic Healthcare Services Scheme. It was nationwide health infrastructure. So it actually establishment of training institutions for human resource for health. So we had a lot of the colleges of technologies and all that being set up, which lower cadre health staff that were necessary to run the primary health care. So this health human resource for health include people like the CHIU, the JCHIU, that is the community health extension workers, the community health officer, and the likes. Note of that. I will not bother us with this, but it just had central points. You have the comprehensive health center, which serves primary health care centers, and the 4 primary health care center has to it. So it was obtainable. So it actually had its essential services, correction of imbalances between rural and urban areas, and between regions of inequity in mind, and this was as at 1980, even before that concept of primary health care globally came into being. So we're thinking ahead, actually. Also to provide health services through health clinics and centers in the communities, cadre of health care staff to accomplish so what limitations of this scheme, which was that it concentrated on provision of health facilities, care workers, but it largely failed because there was little or no attention use of appropriate technology. You know, it was so funny that, you know, there was so you know, on producing this health this cadre of health staff, you know, training them and all that. And then we went ahead machineries and all that, that maybe some were never even used and left to waste away. This was why it largely failed. It was,
Doctor, we could not hear you for a bit there.
yes, I actually muted.
Oh, okay.
Of community participation and use of appropriate technology that largely made it fail. Okay, so bother us with then another thing that we should take note of is the Bamako initiative. And then this was at the 37th WHO regional community meeting of African health ministers held in Bamako, 1987. A way you can remember is that, remember that Ama Ata Bamako initiative, while Ama Ata is 78, Bamako, you turn it the other way, just to help us remember, because those dates can be a bit confusing. WHO Regional African Region, in collaboration with UNICEF, put up a proposal which was aimed at within a context of community participation, thus enhancing the quality of health services delivered to the continent. A cost recovery of initially donated supply of essential drugs at district or local. When you think of Bamako initiative, just think of drug revolving fund. Provide what is called seed monies or the drugs themselves to the primary health care, kind of put a benchmark on it, on how much it can be sold, you know, just add a bit to sell. They are not so much after gain, but just to be able to recover the funds, they add a bit of money and then sell out.
So please, did you say drug revolving fund?
Yes, drug revolving fund.
Okay, thank you.
Yes, that was the major DRF. That was the major thing that came out of the Bamako initiative. It was actually an African regional meeting. So basically, they give them the seed money, the primary health care center That's a bit of amount, then sell the drugs, recover the money, buy some drugs again, and then the drugs were always available to the community, and they are the ones, their participation was very important in this. So it encouraged social mobilization for community participation and of drugs. The implementation of Bamako initiative began in Nigeria and rose to 74 local governments by the year 7 years later. Currently, Bamako initiative 774 local governments in the country. At one time or the other had received seed monies or drugs, stock drugs, or the drugs, as well as funds for training for the program. Partners for Bamako initiative are the federal government, UNICEF, and the United Nations Department for International Development. Basically, what the WHO does is to provide technical support. So in order to ensure government, by decree number 29 of 1992, set up the National Primary Health Care Development Agency, that is NAFDAC. So we should remember that date, that NAFDAC was set up in the year 1992 as a parastatal of the Federal Ministry of Health to give support to the health policy through monitoring of primary health care plan implementation and provision of technical support to PHC implementation. So they monitor and they also provide technical support to PHC. So in 1992, the report of WHO Review Committee noted that community mobilization would greatly be assisted if the boundaries of the health district are same as the electoral ward. So 20,000 to 30,000 people with elected councillor to the local government. So what this place is basically trying to say is this, the word that was there was some kind of distribution that was done then, but it was a bit confusing. Then it's like the word for the health district was not synonymous to the electoral district. Just understand it that way, that there was a health district which was not similar to an electoral district. So we may belong to the same ward, but we don't belong to the same health district. So we don't get our access to maybe health from the same kind of place, something like that. So, but what the WHO was saying then was that it would be more effective if the ward, electoral ward, is synonymous with the health district. So, and that's what we are operating presently. And this concept also came about in the same year as the establishment of the National Primary Healthcare Development Agency. So now, if I'm talking of a health district, it is similar to a electoral district. So say in my where we have a rural practice center, which is Dobi ward. Dobi ward is an electoral ward and is also a health district, such that in Dobi ward we have several primary health care facilities under it that are being controlled under that ward. Okay. So that is just basically that. Then further to this, as part of the federal government's effort to revitalize the primary health care system, the National Primary Health Care Development Agency actually adopted that World Health System in the year 2000. even though it came about in the year 1992, but we adopted it in the year 2000 because the ward is the smallest political unit with an elected councillor in our own political structure. So a terminology that would be good to know about is the Ward Minimum Healthcare Package, which evolved from a meeting of the 16th WHO Regional Program meeting of February 1999. And this meeting discussed the acceleration to attaining health for all. I just want us to know that under this ward minimum package, let's just know the components, most importantly, that part of it is control of communicable diseases such as malaria, STI, HIV, AIDS, and TB. These ones were actually to be treated for free. You know, that individuals within the community could walk into the primary health care center and get access to these healthcare services without having to pay a dime. Child survivors such as neonatal care, routine immunization, maternal and newborn care such as one basic obstetric care center in each ward, then nutrition, non-communicable disease, especially hypertension and diabetes. Those were the two that were covered under the ward minimum healthcare package, and then health education and community mobilization. So I think that's basically what we should just take note of. Then now we're talking of the basic healthcare provision fund. These are recent things that happened, so we should take note of that. This originated from the Health Act of 2014. So basically what this said was that 1% of our income, national income, should be channeled towards health, and there was a sharing formula such that people are able to get better access to health, especially primary health care level. So there were basics, there's certain services that were meant to be free. So people could go to for all those malaria is supposed to be free, antenatal services free, and the rest of them. So let me not buzz too much with the history anymore. So remember the components of primary health care. Personally, I like to classify, because when you classify, you remember and you'll be able to understand and list them better. So for the components, there could either be promotive, preventive, or curative. So personally, what I used to remember is hen pimped. That's about 8 components. Hen pimped. That is starting with the hen, the HEN, promotive components. Then the pimp is preventive, while the PT is curative. So that is.
Doctor, please, can you repeat that?
Okay, I said the components of primary health care, they can be classified as promotive, preventive, and curative. I don't know if you got that.
Yes,
Have you gotten
Doctor,
it? Okay. So the hen is promotive, the PIM is preventive, and PT is curative. So for the promotive, that is things done to promote health, it includes health education, and the health education is actually on prevailing health problems. Health education on promotion of food supply. Sorry about that, excuse me. Okay, so it's just a list of the components. So health education, so education on prevailing health problems and the methods of controlling them. Then for me, the way I arrange it, the next thing will be provision of adequate supply of water and basic sanitation. So I put that under environmental sanitation, which is the E. So it's provision of, but under environmental sanitation, we know that the environment has various components. So water supply, adequate water supply, and basic sanitation are under the environment. Then N is food supply and proper nutrition. So that is the N there. So these three are the promotive components. They are things done to promote health. And then when we are talking of prevention now, we now have a P, prevention and control of locally endemic locally endemic diseases and epidemic. So we prevent this. Then immunization, which is preventive also against major communicable diseases. And then provision of comprehensive maternal and child health, including family planning. So that is the maternal and child health there, which gives the M. Then the PT is now, which is curative, is now treatment of common diseases and injury, then the provision of essential drugs needed for treatment. So those are the 8 components of primary health care. So the terminologies to take care and to be
Doctor, please can you repeat T?
T is treatment of common diseases and injuries.
Thank you.
Okay, so the 8 components are what we've listed. H, health education on prevailing health conditions or health diseases or ailments. Then E, that has to do with environment. So it's provision of adequate water supply and basic sanitation. N is food supply and proper nutrition. Prevention of locally endemic and epidemic diseases, common communicable diseases. M is provision of maternal. The other T is provision of is provision of essential drugs, and T is treatment of common diseases and injuries. Components of primary health care. However, there have been recent additions. Now we are talking of mental health in primary health care. We're talking of dental health care. What you hear is primary dental care, primary eye care, mental health. We're also talking of geriatric care, also in primary health care. So we should just take note of those new additions. So maybe, I don't know if we'll be able to take the principles of primary health care in the next 3 minutes. That will just be about all. And this very, very important. So the principles of primary health care, which are different from the components of primary health care. These ones include essential health care. Remember, in the definition, we say that it's very importantly is the fact that it's essential health care. And what that means is that is the health care that addresses majority of health problems of the people in the community. So what that will mean is that, say, providing services for malaria and providing services for coronary heart disease, which will look like primary health care. even though things are changing, but we know that malaria poses a major public health issue for us, you know. So if we are talking of providing essential care, malaria should be top on the list. Diarrhea diseases should be top on the list. So, and these priority diseases, it actually, that is one thing about primary health care. It's kind of, will I say, flexible or place sensitive, such that what may be my own, what may be the prevailing major issues in my own country may not necessarily be the same as yours. So it has to be adopted in such a way that it addresses my own needs. So one country's major health problem may not be the same as the other country. So, but basically, it should be able to, it should be a kind of healthcare that addresses a community's major health problems. Then there's the issue of equity. This picture I have here, I know it's a popular picture. Here is equality. These people are actually not of the same height. But if you are talking of equality, you give them the same stool, But as we can see, this is not fair. One is struggling to see, the other can't even see at all. But the next adjacent to it is the issue of equity. You give each person according to their need. And that is what primary healthcare addresses, give according to need. Okay, and this leads me to when we are talking about what the BHSS did. It's just allocated. It's like, okay, for every local government or zone, they should have this number. So let's say if we had 6 zones, we'll just say, irrespective of their health needs or the prevailing circumstances, we just say everybody should take one, one comprehensive health center should be established in all 6 zones, not minding whether one place has previous health facilities or places that took care of their needs. So those maybe that had before had more, while some people are still battling. So that's just the issue bit of equality and equity. So equity just means that you give each man according to his needs. So give each community according to their need. So it's a very, very important concept in primary health care. So there should be equitable distribution of health resources, both in terms of manpower, equipment, and medicines for health. All should be equally distributed. So allocation should not be because of a political affiliation. So, and that is what happens most of the time. People establish health, decide because they are from a particular local government area, you decide to so even give them maybe a tertiary institution, not necessarily because of their health needs, but just because they are from there. So those are the issues that equity addresses. So community participation is said to be the most important principle as defined by the Alma Ata of 1978. So it entails all aspects of achieving a good health status, from planning stage through its implementation to enable them assume greater responsibility for their health. So a term to differentiate from this is community involvement. And this is the difference between the two. For community participation, remember when we were talking about the planning circle or management, we talk of PI, which is planning, implementation, evaluation in management. So when you are talking of community participation, they are involved right from the planning stage through the implementation, and even when you are evaluating to determine the success of your program. So unlike involvement whereby you plan, then possibly when you are implementing, you now call them or something, just get them involved, So participation is more encompassing compared to involvement. And what community participation helps them to be that it helps them to take ownership of the program. And it's this is why it's said to be very, very important, because whether whether they take ownership or not will determine the success of the program and whether this program will be sustainable. If they believe it's your program and you just brought it to them, when you go, be sure that you are going with your program. When you leave, nothing will continue. But when the community is involved from the beginning, when you are doing your situation analysis, trying to know what are their felt needs, despite what you perceive to be, when you get them involved from that moment, get their inputs and all that, they tend to have a sense of belonging and own the program. And then the program tends to be successful compared to when the program is just dumped on them. A popular story that has to do with community participation was a community where it was noticed that they lacked water supply. So the organization just came and dug boreholes for them. But they now realized that despite the fact that the borehole was available, the women were still not using them, were rather still sending their children to the stream to get water. And what was the issue? It was said that what their major problem was poor housing. There were just maybe a family of how many children. So the times that the couple sent their children to the stream to get water was when they had privacy. And so you can imagine why this program will not be successful, because they were not involved from the beginning. So it's as much as you have good intention, it is always good to involve them in the planning from the beginning and know what their own felt needs are. And that is the way you can get their participation and ensure that the program is successful and sustainable. This is just basically steps in community participation. You plan together, you let the community members implement the program, and they also evaluate. So appropriate technology. Remember, we said that this was one of the reasons why the BHS failed, because they didn't make use. In our time in Nigeria, where our power is very erratic, you now provide technology in refrigeration or freezer, require power to run it, because we don't have continuous power. And so if you use those stuff for storing vaccines, it's going to fail. So it will be more appropriate to provide us with something that we can handle. An example is the use of solar refrigerators in our primary healthcare centers and freezers to store our vaccines, because we have a lot of solar energy. So that is not a problem. So in that case, that is now an appropriate technology. So another thing, the biogas. So instead of providing maybe you're saying you're connecting them to where they have to pay and where they use liquid natural gas or all that, make their own biogas from a small plant they can make in their own cow dung, vegetable waste from the kitchen and all can use for cooking. So this is basically what technology is about. Once we read it, we'll see more examples on that. So example of appropriate technology salt, growth charts, the vaccine monitor on vaccines that makes it easy to read, which has like 4 stages.
Doctor, we can't hear you.
Okay, so I said I was talking about examples of appropriate technology. So I talked of ORS, growth charts, vaccine monitor, which I said has 4 stages. Usually on every vaccine, you see a circle that has a central square. So this central square, initially at stage 1, the central square is white, while the outer circle is grayish. So when you see that kind of vaccine, it means it is potent and can be used. This vaccine vial monitor is actually heat sensitive, so it changes over time depending on exposure to heat. Then for stage 2, still lighter compared to the outer Dicas cycle. That is called stage 2. For stage 3, both of them are gray. They are in the same color, and that means that it is no longer viable. It is no longer potent. Then for stage 4, it means that the inner square is even darker than the outer circle, which means it's also not potent and cannot be used. So let's just take note of that. So I gave some examples of appropriate technology. Then self-reliance. This entails the use of what is available in terms of financial, human, material, and other resources to achieve some goals. So the people should actually be able to mobilize resources that would help sustain the program. So they should be able to maintain the program or what you are providing for them. Then intersectoral collaboration, all hands needs to be on deck. So it's everybody's business. So health is not just about the health sector. So there's intrasectoral, and then there's also intersectoral. Intrasectoral means all cadres and all disciplines within the health sector. So both the nurses, the doctors, the pharmacists, medical lab scientists, they all need to work together. Then intersectoral, both agriculture, environment, and all that. We all need. So I think it would be good. This would be a good place to stop. So those are just a code I also use in case we forget appropriate technology, self-reliance, intersectoral collaboration, community participation, and essential.
Also, please, can you repeat it? Your voice was breaking for it.
Okay, so I said for about 6 of them, use ICE. Use ICE. So use of and self-reliance, essential healthcare, intra-sectoral and intersectoral collaboration, community participation, and equity. So those are the principles. Good place to stop this evening. I don't know if there are any questions or clarification. Thank you.
Thank you so much, Doctor. No, there are no questions about this topic, but I had a question about control, disease control.
Okay.
So
I can hear you.
Doctor, does disease control include reducing complications?
Yes. The thing is that some complication. So I would say yes. I think a reference would be know did not actually include for most people seeing incidents, reducing is both morbidity, mortality, reducing what do you, and also reducing financial, but then some texts include reducing complications. I think the reference is PACS.
Okay, thank you, doctor. So reducing complication over even reducing prevalence.
Kindly repeat yourself.
If I were presented with like two options, like for disease control, reducing complications and reducing prevalence, I felt like reducing prevalence was the better option for what is involved with disease control. Is this correct?
Okay. I get in other options.
What did you say, doctor?
So what were the other options?
Okay, so reducing complications, reducing risk of transmission, reducing incidence, and then reducing prevalence.
If there's incidents there, then I would odd one out. However, we know that prevalence is a product of which what we discussed the last time, but then complicated as prevalence is just a reduction in incidence, reduction in duration. So I would go for
Doctor, I couldn't hear you.
okay. I said back when talking about control, text include. So from what we discussed the last time, we talked about reducing incidence, reducing duration, reducing financial and all that. So, and we know that prevalence is a product of incidence and duration. You understand? So if I'm present options, I would rather go for prevalence as the because the text do not outrightly put it as reducing prevalence.
All right. Thank you so much, doctor. Thank you for your time.